of greater than 10% usually confer greater benefits, including disease-modifying effects and possible remission of type 2 diabetes, and may improve long-term cardiovascular outcomes and mortality. And we've seen so much information this year, especially with some of the new medications that have been approved on weight loss and how that may possibly impact remission for individuals with type 2 diabetes. In 2019, as many of you may be familiar with, the ADA produced the Nutrition Consensus Report, which is for adults who are non-hospitalized, age 19 and over. And in the consensus report, you will see a number of recommendations on a variety of eating patterns, which we will now look at, and you will also see other recommendations. However, if you don't see an eating pattern that you might be familiar with or suggest for some of the individuals that you work with, that's because there may not have been enough evidence for a person with type 2 diabetes or type 1 diabetes or prediabetes to have been published in the report at that time. And it also stated that low carbohydrate meal plans have the largest impact on glycemic management. So let's look at some of these eating pattern definitions. Low carbohydrate eating patterns, and again, this goes back to the nutrition consensus statement and some of the other reports in the standards of care. And the studies reflect, the studies were done showing carbohydrate intake on a low carbohydrate diet of 26 to 45% of total calories, and a very low carbohydrate diet is a carbohydrate level of less than 26% of total calories. And sometimes you may see a very low carbohydrate diet referred to as a keto diet, but we're using it on the eating pattern definitions with the consensus report here. You may also see some of the very low carbohydrate eating patterns referred to as less than 20%, but for the purposes of these studies and what was reviewed, it's less than 26% of total calories. Important to point out when you're reading any research, any evidence-based data, any suggestions, is that research in people with type 2 diabetes cannot automatically be translated to a person with type 1 diabetes. And the other way around is true. If you're seeing research for people with type 1, that cannot automatically be shown for people with type 2. There are a number of eating patterns that are shown to potentially achieve type 2 diabetes remission. Most of the studies on type 2 diabetes remission have to do with bariatric procedures and low-calorie diets. There is research to show the other eating patterns that we're going to look at here. One is the low-carb and very low-carb eating patterns, the low-calorie eating patterns, plant-based eating patterns, the Mediterranean eating pattern, and intermittent fasting. And intermittent fasting, we're seeing more and more data come out in this area, but there wasn't as much evidence in studies, so that's not reviewed very thoroughly in the nutrition consensus report, but we've seen other data come out since that time. The low carbohydrate eating pattern suggests many low carbohydrate vegetables, including salad greens. We'll always recommend dark green leafy vegetables, right? Broccoli, cauliflower, cucumbers, cabbage. It also may include, depending on an individual's preferences, animal foods, vegetable oils, avocado, proteins such as meat, poultry, fish, shellfish, eggs, cheese, nuts, and seeds. It de-emphasizes the consumption of starchy foods such as pasta, potato, concentrated sugars and sugary foods such as full sugared sodas and candy, and refined carbohydrates such as white bread. So we're promoting more complex carbohydrates when they are included in a low carbohydrate eating pattern, including beans, legumes, lentils, etc. Those should be included. The benefits of a low carbohydrate eating pattern may include hemoglobin A1C reduction, lowered needs for anti-hyperglycemic medications, and weight loss, lowered blood pressure, and increased HDL cholesterol, and lowered triglycerides. For a low-fat eating pattern, which if you go along with the guidelines from the 2020 to 2025 dietary guidelines, the low-fat eating pattern recommends eating less than 30% of total daily calories from fat and only having 10% of those calories coming from saturated fat. And that includes vegetables, fruits, starches, lean protein sources, including beans, those complex carbohydrate beans, and low-fat dairy. And of course, in reviewing all of these different eating patterns, there doesn't have to be any one specific eating pattern. It can be a combination of these different eating patterns that are individualized. Potential benefits of a low-fat eating pattern includes a reduced risk of diabetes and weight loss. A plant-based eating pattern, which previously was mostly referred to as a vegetarian eating pattern, but it is a plant-based eating pattern. If we look at vegetarian, it's devoid of flesh foods, but if somebody is a lacto-vegetarian, they would include eggs. And if they are lacto-vegetarian includes dairy products, and an ovo-vegetarian would include eggs. So if you hear somebody is a lacto-ovo-vegetarian, they are also including dairy and egg products with their plant-based eating. A vegan pattern is devoid of all animal-derived products completely. And the potential benefit of a plant-based eating pattern will reduce the risk of diabetes, A1C reduction, weight management, lowered LDL cholesterol. The Mediterranean eating pattern, which so many people are embracing these days, emphasizes plant-based foods such as beans, legumes, nuts, and seeds, fish, olive oil. And the potential benefits of the Mediterranean eating pattern include a reduced risk of diabetes, A1C reduction, lowered triglycerides, reduced risk of cardiovascular events, many benefits that we see there. So intermittent fasting, again, very interesting, is an eating pattern that switches between fasting and eating on a regular schedule. And we know that for many people with diabetes on medications, this can be very, very tricky, especially if someone tries to do this on their own. And there are multiple methods to choose from, and it's based on personal preference, including these are just some examples: time-restricted eating diet, the 5-2 diet, eat, stop, eat diet. So I just included a few of them here to take a peek at what you might hear from some people who are looking at your expertise on this. Some of the benefits of intermittent fasting include reduced risk of diabetes, weight loss, weight management, improved cardiovascular and neuromuscular, neurological health, and reduced risk of certain cancers. So let's look at these types of eating patterns and some of the potential benefits reported. And again, I encourage you to take a very deep dive into the Nutrition Consensus Report and then the updates in the standards of care. There are many more eating patterns, but these are some of the main eating patterns that we come across. So in the low carbohydrate, we see the A1C reduction, potential weight loss, lowered blood pressure, increased HDL cholesterol, lowered triglycerides. With a plant-based or vegetarian or vegan eating pattern, we see a reduced risk of diabetes, A1C reduction, weight loss, lowered LDL cholesterol and non-HDL cholesterol. In low fat, reduced risk of diabetes and weight loss. And in Mediterranean eating patterns, reduced risk of diabetes, A1C reduction, lower triglycerides, reduced risk of major cardiovascular events. It should be pointed out that in the low carbohydrate eating pattern and the very low carbohydrate eating pattern, which we will talk about in a few minutes, there are some groups that are not recommended to follow those eating patterns. So looking at a little bit of a deeper dive into intermittent fasting, that's an umbrella term. That's why I gave you so many different options that we see in the intermittent fasting world, such as the alternative day fasting energy restriction of 500 to 600 calories per day on alternate days, which is extremely restrictive and devoid of a lot of nutritional benefits. The 5-2 diet, energy restriction, again, and a time-restricted eating, which is a daily calorie restriction based on a window of time of 8 to 15 hours. So in each of these intermittent fasting restrictions, it does produce a moderate weight loss, about 3 to 8% from baseline over short duration. So the study durations were really only 8 to 12 weeks. There haven't been any significant long-term studies on intermittent fasting. What they did not see are significant differences in weight management when compared with continuous caloric restriction. So in other words, the intermittent restriction was not that different in terms of weight loss compared to calorie restriction. Very interesting. And we want to, no matter what eating pattern a person is following, make sure that people take in an adequate amount of fiber, which is such an important and vital part of our nutrition plans. Fiber supports weight management. It increases satiety. It may reduce cholesterol and blood sugar levels. It lowers the risk of cardiovascular disease, including stroke and heart disease. It may lower the risk of developing prediabetes and type 2 diabetes. It also improves digestive and bowel health. And we're hearing so much and learning so much about the healthy gut bacteria. We know that fiber plays a role in this as well. Women should increase their fiber intake to about 25 grams of fiber per day. And the suggestion for men is a minimum of 38 grams of fiber per day. However, if you're working with an individual who is currently taking in 5 or 6 grams of fiber per day, and they're not consuming an adequate amount of fluid, hopefully in the form of water, then going from 5 or 6 grams of dietary fiber per day to 25 is certainly not recommended. And it is recommended to take in 14 grams of fiber per 1,000 calories. So if somebody is consuming 2,000 calories per day, then the recommendation would be 28 grams of fiber. I also give a very simple, I had this discussion with a client the other day. It's a very simple discussion about water, and some people are not naturally thirsty. So they have to be encouraged to drink more fluids and more water. And we talk about different ways to do it. And one way that I explain it is if a hard sponge is sitting on your sink, and you don't add water to it, it stays hard. And when you add water to it, it expands. And it's a great way to really manage water and fiber intake, to put it in a visual way. Fiber should, of course, come from soluble and from insoluble sources. So getting fiber from a variety of different sources is important. We want to recommend an adequate intake of low carbohydrate, high fiber vegetables in different forms. And so that's a great way to get a lot of fiber without increasing carbohydrate intake. And in terms of complex carbohydrate, foods like beans or lentils, which are excellent, especially in increasing plant-based eating and reducing, if you're looking to consume less animal foods for whatever reason, or less animal fats for whatever reason, as long as the carbohydrate content is also considered, the fiber content is obviously of benefit and may also help to manage blood glucose levels. I love the diabetes plate method, and this is often something that is completely underused, especially when we are having quick discussions with people about diet. Sometimes we don't have a lot of time, and a lot of others on the healthcare team, a lot of clinicians who are not diabetes care and education specialists, who are not registered dietitians, or who may not be familiar with nutrition, ask for a quick way that they can open up a discussion about nutrition. So the diabetes plate method refers to a standard 9-inch dinner plate. And I think this is a great visual because we're not talking about a huge, big platter that we might use from Thanksgiving when we talk about the plate method. And the recommendation is to fill about half of that 9-inch plate with non-starchy vegetables. For example, broccoli, Brussels sprouts, asparagus, mushrooms, cauliflower, dark green leafy vegetables, eggplant, and to fill a quarter of the plate with carbohydrates. And we will try to go, when possible, with those complex carbohydrates. And filling a quarter of the plate with lean protein, fish rich in omega-3 fatty acids, white meat, poultry, tofu, low-fat dairy, beans, legumes, etc. And then to give an example for somebody so that they can actually see what the plate looks like. And again, promoting the intake of water, choosing water or a low-calorie beverage, sparkling water, unsweetened tea, diet soda, if that's something that you individually feel is a good suggestion, or black coffee. There is a low-carb plate method that has also been suggested, and here we fill half the plate with the non-starchy vegetables and the other half of the plate with the lean protein, again encouraging to drink water or a low-calorie drink. And you can see how this looks different, but it is a very good explanation. Again, another reason for this to be extremely individualized is looking at calorie levels, individual acceptance, and this is the way that the low carbohydrate plate method can be very easily described if you're working with an individual that may want to adopt that option. A very low carbohydrate diet followed for a long period of time may pose cardiovascular risk, and that has been shown in several studies, so that must be considered as well. So if somebody is interested in adopting a low carbohydrate eating pattern or a very low carbohydrate eating pattern, it's important to discuss several considerations, such as monitoring blood glucose, the keto flu, and the possibility of dehydration. So in monitoring blood glucose, the emphasis and the importance of checking blood glucose levels and monitoring hypoglycemia is very important, especially if the person was consuming a large amount of carbohydrate before adopting this type of meal pattern. The keto flu, I don't know if you guys have heard of this, but somebody who is following a very low carbohydrate eating pattern, which may be less than 20% of total calories of carbohydrate for the day, to make them aware that the keto flu may last 2 to 3 days, but it could last up to 2 weeks. And this is when the body is transitioning to this type of eating pattern, and the person may develop flu-like symptoms such as dizziness, lightheadedness, headache. This really needs to be addressed with increasing fluid intake and potentially increasing electrolyte intake, including salt intake if appropriate. And of course, we know that that may not be something that we consider for many of the people that we work with diabetes, as the recommendation for sodium intake is less than 2,300 milligrams per day. So this is a temporary side effect, but something that people should be aware of. Also, reducing carbohydrate may place a person at increased risk of dehydration. Many of the carbohydrate-containing foods also provide water, such as fruits and vegetables. It could be as much as 20% of a person's daily fluid intake can come from foods that do provide fluid that contain carbohydrate. So following a very low carbohydrate eating pattern, a person should be encouraged to, unless there's a reason why they shouldn't, 64 ounces of water per day. Another way to estimate daily fluid intake is to divide a person's body weight in pounds by 2. So if you have a 200-pound individual, they would require approximately 100 ounces of fluid a day. And also to make a person very aware of the signs of dehydration. So if someone is experiencing extreme thirst, dark colored urine, less frequent urination, fatigue, dizziness, confusion. Encourage people to drink more fluid when they experience these symptoms. A very low carbohydrate eating pattern is not recommended for several situations, and this includes pregnancy and breastfeeding, chronic kidney disease, if someone is taking SGLT inhibitors, and here are some of the generic names for SGLT2s listed here, and evidence of an eating disorder or disordered eating. Let's take a deeper dive into this for a moment. It's extremely important and something that's often overlooked. When a person is diagnosed with prediabetes, type 1 diabetes, type 2 diabetes, oftentimes food is something that is discussed everywhere all the time, from healthcare professionals, from well-meaning family members, even from colleagues, coworkers who you're not asking their opinion, but they're telling you anyway. So we know with the always talking about nutrition and how it is tied to so many different aspects of diabetes that we have to screen and really listen when we're providing this type of education to see if somebody is exhibiting any signs of eating disorders or disordered eating behaviors. It's really something that's important and often very overlooked. So active listening is important when using all of these tools and strategies. Tools and strategies for eating patterns education. So I'll point out here that I'm using visual, very old school kind of things as I'm going through these lists, but know that there are, I think at last count, 1,200 different diabetes related apps, and there were over 350,000 nutrition, lifestyle, and health apps. So there is a lot to choose from, and we can talk a little bit more about apps in a bit, but these are just some tools and strategies to use when discussing eating pattern education. When a person is first diagnosed with diabetes, and we are, of course, providing this initial education, don't assume that people know what low carbohydrate foods are. So understanding and using low carbohydrate food lists is very, very important. If a person has lived with diabetes for a long time, they may need a re-education on this, or they may have had some changes in their plan, and it would be beneficial for them to have a re-education on this. And figuring out if this person would benefit, like I said, from using a number of different nutritional related apps may be very important. Another thing that's very important is to identify the carbohydrates of what a person is currently consuming. So looking at foods that they are eating and helping to identify which foods contain carbohydrate, which foods are lower in carbohydrate, what their food preferences are, what their budget is, what their cultural backgrounds are. All of this is very important to discuss and to explore. We don't talk about nutrition label reading enough. And if somebody does not understand a nutrition facts panel, then that can be an issue in all aspects of their nutrition education. So looking at a nutrition facts panel, and these came out a number of years ago now, the new nutrition facts label, the calories are in bold and everything is based on one serving. So one serving of this container is 2/3 of a cup. If you eat all 8 servings, you have to multiply everything on here times 8. If we look at the total carbohydrates, that's the number that we're generally having people look at it. And so the total carbohydrates are listed on here, the fiber and the total sugars. And what's important to also point out is that it includes added sugars. So a confusing aspect of the food label for some people is they may look at each of these parts individually and not just the total, and not really looking at the total carbohydrate as including these different pieces. And this is nice because it also shows the amount of dietary fiber that's on here. What you won't see on a nutrition facts label, but you will see on the ingredients label, if you are interested in learning more about non-nutritive sweeteners, which have been discussed a lot lately, that's something to look at on that label as well. So in other words, if it shows sugar alcohols or things like that, that would be listed on the ingredients labels. So also understanding a great deal about carbohydrate counting and how to do that. And I know I'm using something old-fashioned now, but again, using a number of different, you can use free app programs such as MyFitnessPal. You can use Under My Fork or Figwe. There are a number of different nutrition programs and apps to use, and I would be glad if we have time in Q&A to go into that in a lot more detail. And we talked about the plate method, which again is not a perfect approach, but I wanted to point it out here for some patients, especially some who may prefer it or who may feel overwhelmed. This is a really great place that you may want to start. Connection with the healthcare team is so important. Blood glucose must be regularly monitored. Insulin and insulin secretagogues need to be reduced substantially at the time an individual starts to reduce their carbohydrate intake. Monitor blood pressure medications, especially diuretics. You may need to reduce them at eating pattern initiation or over time with weight loss. So this is very important. If a person starts a low carbohydrate or a very low carbohydrate eating pattern, that may affect more than their weight, that may affect their need to monitor blood glucose more regularly, modify their exercise pattern. That might mean a change in their blood pressure medication, etc. And also to have support from someone who is knowledgeable and can troubleshoot as needed. So another part of remission in type 2 diabetes that we've seen a lot of discussion about is the effects following bariatric surgery and bariatric weight loss. And the exact mechanism for type 2 diabetes remission following bariatric surgery is not fully understood, but there have been a number of recommendations. I see a question come in that says, I hope that you're not recommending 60 grams of carbohydrate per meal. So I'm going to address those at the end. These are recommendations that are coming out of consensus report data and from the ADA standards of care. But we can talk about specific recommendations during Q&A. It requires not only what patients and individuals with diabetes are consuming, but our clinical judgment based on the person's individual needs. So we can totally talk about that during Q&A. So going back to bariatric weight loss, reduced caloric intake leads to significant weight loss and improved glucose sensitivity, and initially thought to be achieved via restrictive or malabsorptive properties of bariatric surgery. However, this does not explain the drastic effects that are seen on glucose control immediately following surgery. So it's not completely explained by this. And the majority of glucose lowering achieved prior to substantial weight loss. So what they're saying is in a lot of the research is that we see an immediate effect even before there is a long-term weight loss from bariatric surgery. So let's take a quick view of some of the common types of bariatric surgeries. We have for those who are not familiar, we have the adjustable gastric band, which is the lap band. And the lap band is placed around the top of the stomach. Less solid food can be eaten at one time, and food passes through the band slowly, resulting in a longer feeling of fullness. Using a port placed under the skin, the size of the band and the speed that food passes can be adjusted. So you may have worked with some clients or some patients who have had the lap band surgery, and over time, it may have stretched out or changed, and they may go in for a lap band adjustment. Again, I am not recommending bariatric surgery. We are reviewing it because it is part of the consensus statement and a lot of the research on remission related to type 2 diabetes. Then we have a full gastric bypass, where a large portion of the stomach is closed off. This leaves a small pouch to hold food. Less food can be eaten at one time, and the small intestine is cut and reattached to the new pouch. This bypasses about a third of the intestine, shortening the time the food is in the intestine. I have seen much less of this surgery. 15 years ago, this was common practice. Because of malabsorption issues, I do not see a lot of this surgery in my practice. What does happen sometimes is I do often get requests of letters because they need a dietitian to sign off prior to surgery. So this is something that they may reach out if they're having any of these bariatric procedures to see if they are signed off by a dietitian, making sure they don't have binge eating behaviors, for example, and that they are potentially going to follow the recommendations from the surgical team and the nutrition team following the surgery. Appetite is often significantly decreased, especially for the first 3 to 6 months after the bypass surgery. One that is more common in recent years is the vertical sleeve gastrectomy surgery. In this surgery, a large part of the stomach is removed. This results in a feeling of fullness after eating a smaller amount of food, and removal of this part of the stomach also results in decrease of the hunger-inducing hormone ghrelin. And finally, one that which is probably the least common one that I've seen, is the biliopancreatic diversion with the duodenal switch surgery, commonly called the switch surgery. And in this one, part of the stomach is removed. The small intestine is cut and reattached to the new stomach pouch. This bypasses most of the intestine, and less food can be eaten comfortably at one time, and food spends much less time in the digestive tract, so fewer calories are absorbed. And in all of these surgeries, nothing is for free. It comes with, like I said, malabsorption. Sometimes we see extreme losses of bone mass, osteoporosis after many years of some of these types of surgery. Insulin sensitivity post-bariatric surgery. This is what leads to a great number of the studies showing remission, is that there is a significant decrease in insulin resistance. Insulin resistance decreases about 50% in 1 week following surgery. Again, we see this insulin resistance decrease following surgery before there is a large amount of weight loss. Improved liver insulin sensitivity. Insulin clearance also increases, and likely due to a decreased caloric intake, which in turn leads to decreased liver fat content. And combined together, these effects in turn lead to decreased basal glucose concentration and are thought to improve pancreatic beta cell function by decreasing the toxic effect of glucose. This is again in people studied with type 2 diabetes. GLP levels rise dramatically within days of the bariatric surgery, stimulating that pancreatic beta cells. And if you want to get into a little bit more detail, here is a graphic that you can review about it. And this is what is so interesting. The hypothesis explains the benefits on the full gastric bypass and the switch, but it doesn't explain the beneficial effects on glucose metabolism seen in the sleeve, as the intestinal tract remains in continuity. So we're still learning a lot more about the effects of bariatric surgery on diabetes remission. There was a fantastic user guide that I would really recommend everybody to review that came out in 2022 through the Canadian Journal of Type 2 of Diabetes, and this will be in a resource at the end of my presentation. And here's one of the graphics from that journal article and that user guide. It's really fantastic. Recent studies show that the remission of type 2 diabetes can be possible And this is for a subset of individuals with type 2 diabetes, because for some, even following bariatric surgery or following many of the lifestyle modifications, and again, most of the studies did look at the low-calorie diets, it didn't even include physical activity. So even with the bariatric surgery and the nutritional modifications, we saw this remission based on the guidance and the guidelines and the information of confirming the remission that we showed in the consensus statement at the beginning. So this also really has the person with type 2 diabetes with a prolonged commitment, and there is relapse that might be possible. So careful assessment has to be given to people who may have, again, eating disorders, disordered eating, mental health disorders, or concurrent medical conditions that have to be addressed. Why? Because remission, as they point out in this article, is a journey, and it may take a person several times to arrive and to maintain remission. So, and for some people, they might not achieve remission, which can be very frustrating. So if you want to look into much more detail about how to achieve this remission, then take a look at this user guide. It was really very helpful for me to review for this presentation. There were 4 approaches to achieve and maintain weight loss for people with higher body weights and obesity that include healthy behavior and lifestyle changes, intensive evidence-based structured weight management programs, medications for weight loss, and metabolic surgery. And of course, through all the eating patterns, mindful eating approaches, other approaches that include individualized behavior and concerns, that's where our clinical judgment comes with all this evidence-based information. I'm including this chart that I don't expect you to read off a PowerPoint, but what a great resource and reference. The Association of Clinical Endocrinologists, ACE, produced this weight loss medication chart this year that I thought would be so interesting with all of the information that's recently come out about the GLP-1s and their use and their approval and who they should be used for. So again, this is profiles of weight loss medications for people with diabetes. And you can look at the class of the medication, the amount of weight loss that's expected, the mechanism, the way that it's delivered, the dosage, the treatment dose, the potential side effects. Remember, you don't get anything without having some of these side effects with any of these medications, some of the cautions and contraindications, and the cost. So this is a great chart to review if you were interested in learning more about some of these medications that patients may be on. There are so many reasons and causes, as we well know, for type 2 diabetes. But if a person does maintain or achieve remission and does then consume excess food energy in terms of calories, then that can cause remission to go back, and the person can then be in status for type 2 diabetes again. So the summary for remission in type 2 diabetes is that remission can be achieved by sustaining normal blood glucose levels for at least 3 months without taking diabetes medications. Still uncertainty around how long remission will last and what factors are associated with relapse. And continued follow-up with the healthcare team is needed for ongoing monitoring of glucose changes and diabetes complications. And we have to be careful also in our terminology. We're using the word remission here, not reversal, again, because we want to keep on monitoring a person with type 2 diabetes to see if remission is continuing. The long-term effects of remission on mortality, heart rate, and quality of life are not well understood, but are continuing to be studied. So now let's move on to the next part of my presentation, which is the benefits of physical activity for people living with diabetes. And oh, there are so many. Exercise helps to manage blood glucose. It increases insulin sensitivity, so your muscle cells are better able to use available insulin and to take up insulin during various activities. If you have diabetes, your body can become more sensitive to insulin with increased physical activity. I'm also very strong on language. For a lot of people I work with, I don't use the word exercise. They look at it as a word that they don't like. So we use increased physical activity. When your muscles contract during activity, your cells are able to take up glucose and use it for energy, whether insulin is available or not. It takes up extra glucose. An immediate benefit of exercise is it helps to lower excessive high blood glucose levels. Exercise triggers the uptake of glucose from the bloodstream into the working muscles and the organs. And this is one reason that people agree that elevated blood glucose levels may be a big benefit of just taking a simple walk after a meal, if that is potentially possible. It lowers the risk of heart disease and nerve damage. It could help maintain or lower body weight in many circumstances. It encourages a higher metabolism. In the process of weight management, if we're losing body fat and maintaining lean body weight, that encourages a much higher metabolic rate. It helps to lower blood pressure and LDL while increasing HDL or high density lipoprotein. Oh, and it does improve mood with those endorphins, memory, and sleep. And we'll be talking about sleep in a little while. Sleep is one of the most under-discussed issues in good diabetes management and quality of life for people living with diabetes. In 2023, the ADA Standards of Care had a number of updated exercise recommendations. And some of these are also included from previous standards of care. So let's look at some. Let's fill in the blanks. How many minutes of moderate or vigorous intensity aerobic exercise with muscle strength training and both strength exercises for how many days a week? So greater than 60 minutes of aerobic exercise at least 3 days a week. And most adults with diabetes should engage in 150 minutes or more of moderate to vigorous intensity aerobic exercise per week, spread over at least 3 days with no more than 2 consecutive days without activity. Shorter durations, a minimum of 75 minutes per week of vigorous intensity or interval training may be sufficient for younger individuals and more physically fit individuals. So it's important that I discuss with clients these days the importance of not going more than 2 consecutive days without activity. This has become extremely important to me since COVID. I had an in-person practice for almost 30 years, in a brick and mortar office. And in March of 2020, for obvious reasons, switched to a telehealth practice. And everybody at the beginning of COVID really sat and streamed a lot of TV, and a lot of things went remote. So bringing up the importance of exercise is so important for everyone, and in particular for people with who are living with diabetes. And we want to have 2 to 3 sessions per week of resistant exercise on non-consecutive days. And again, this is something that really needs to be individualized. Decrease the amount of time spent in sedentary behavior. Prolonged sleep sitting should be interrupted every 30 minutes for the best glucose benefits. So, and before I talk about the hypoglycemia prevention, the aerobic activities are, of course, very important. And we talked about it with weight management, including walking, jogging, skating, cycling. But we have to talk about things like gardening and dancing and other activities, cleaning, anything that somebody can use to move around. So some people feel like if they don't walk or jog or do those type of activities, they're not exercising. Not true, as long as you move. Hypoglycemia prevention. Monitor glucose. Check your blood sugar before, during, or after physical activities, and look at a number of different variables: the intensity of the activity, the length of time you will be active, any recent changes you've made to your medications or your insulin dosages, and be prepared if you're going to be exercising where you may have not before, or if the exercise intensity increases. Pack a glucose source that will be readily available during or after exercising. So aerobic metabolism from the aerobic activities take place in the mitochondria of the cells, and its ability to use carbohydrates, protein, or fat as fuel sources. And it increases how quickly insulin picks up glucose and carries it to the cells, because you're demanding more glucose to keep your body moving and to keep your body performing. Exercise and glycemic management. Hypoglycemia and hyperglycemia. And sometimes people experience a drop in their blood sugar during exercise. So as we said, it's very important with that management. But strength training or anaerobic high intensity exercise, like weight training, can produce counter-regulatory hormone responses like norepinephrine, epinephrine, adrenaline. Those may come into play with resistance training and strength training. That fight or flight syndrome, where there can be a glucagon release, and those are exercises that you can't keep up for a very long time. So that's why sometimes after intense strength training, you might experience a rise in blood glucose level. Some people who are starting strength training may feel that they need to decrease insulin and increase when they do increase that strength training activity. So that's important. And the effects of those muscle contractions, muscles can use available insulin to take up glucose both during and after a workout. That's why the importance of continuing to monitor blood glucose before, during, and after. And if somebody is embarking on a whole new exercise program, having discussions with them about CGMs can be very helpful. Physical activity helps cells burn glucose for energy as the muscles contract. And being active allows glucose to leave the bloodstream and enter cells that require energy, resulting in a drop in blood glucose, regardless of whether or not the insulin is available. So the type of exercise, as we were just discussing, matters. Aerobic exercise, the glucose can trend down. There are many variables: the intensity and the duration of the exercise, the insulin to glucagon ratio, the fitness of the individual, their nutrition, what they're eating, and the initial glucose concentration. For some, if you're doing mixed, the intensity and duration of exercise, insulin to glucagon ratio, counter-regulatory hormones, lactate concentration, fitness, nutrition, initial glucose concentration. And anaerobic, intensity and number of intervals, insulin concentration, counter-regulatory hormones, lactate concentration, fitness, nutrition, and initial glucose concentration. So again, this is where our clinical judgment can be so helpful. If a person is doing a lot of aerobic activity, but they want to start to increase their strength training or their weightlifting activities, more of anaerobic activities, that may be, and they know that when they're doing that, that blood glucose level is raised, and when they're doing the aerobic activity, their blood glucose level is lower. Perhaps it would be advisable to do the strength training at the top of the workout, which may raise blood glucose levels, and then do the aerobic activity. For some people, it can be mixed. But it's a great discussion to have with clients who have become really shy about exercising because of their hypoglycemic reaction after exercising for, which is something that they don't want to happen again for obvious reasons. So we talk about aerobic exercise and strength training exercise. And one thing that we don't talk enough about is flexibility and balance training, which is recommended 2 to 3 times a week for older adults with diabetes, but I say it should be recommended for everyone. Yoga, Tai Chi, those type of exercises based on individual preferences, can help to increase flexibility, muscular strength, and balance. And please, people don't have to go to a gym if that's not something they can prefer. There are many great options on YouTube, other videos, other apps and ways to be able to do these things at home if that is somebody's preference. Balance training. Any balance exercises can help to prevent falls, especially for people over 40 or those people with peripheral neuropathy. Balance exercise lowers body core, helps the lower body, helps to increase core strength, functional fitness, agility, gait, coordination. Try all of these different exercises and recommend them. And we know that there is so much that is tied to increased physical activity and the benefits for people with type 2 diabetes. And they're all listed here, but the benefits are really unique. And of course, all of our recommendations are based on a person-centered, non-judgmental approach to care, but it will affect all aspects of a person's being, including their strength, their sleep, their ability to be able to function, their mood, just in every single way. So this chart calls that out as well. There is a great impact of exercise on cardiometabolic health on people with diabetes. Breaking up prolonged sitting can help to improve so many different aspects, as we see here. Also, stepping more, what the benefits of strength training and having adequate sleep, good sleep quality, all of these different impacts of behavior on cardiometabolic health are shown here. We're going to also point out, and something that I'm not covering today, but a lot of what we're talking about with exercise, and when we spoke about nutrition, and when we speak about sleep, is the effects of physical activity and adequate sleep on mental health, on reducing depression and reducing anxiety. There is so much burden and so much that a person with diabetes hears in terms of information that it's very overwhelming, and therefore it doesn't allow a person to make any changes because they feel overwhelmed with all the changes that they need to make. So in cooperation, in collaboration, in understanding what the goals of a person with diabetes are, always focusing on their quality of care and what their goals are of care, these things can, as we see in the final column, improve quality of life. And that is, of course, our ultimate goal that we are trying to suggest. So, as I said, there were two things that I find very under-discussed in terms of our initial assessment for people with diabetes. One of them, to me, is sleep and sleep hygiene. And the other one, which I won't discuss as much today, if we have time in Q&A, I will a little bit, is not, we have to screen more for hearing loss in people with diabetes, because if we don't recognize hearing loss, all of the communication that we are talking about today might be very missed and maybe misinterpreted as a person not being communicative. So let's begin here with talking about sleep hygiene and around the bedroom environment, and how daily routines that promote consistent and uninterrupted sleep can help a person with diabetes. It's estimated that 1 in 2 people with type 2 diabetes have sleep issues. And part of that might be due to having not well managed blood glucose levels, and high blood sugar levels or low blood sugar levels can lead to issues at night, like insomnia or fatigue the next day, or feelings of anxiety or being stressed out, that could definitely affect people with diabetes as well. So less than 7 hours of sleep per night can affect diabetes management. Getting poor sleep or less restorative, slow wave sleep has been linked to higher blood glucose levels in people with prediabetes and with type 2 diabetes. And about a quarter of people with diabetes report that sleeping less than 6 hours a night puts them at higher risk of higher blood glucose levels. So too little sleep can increase insulin resistance. And of course, everything that we're talking about today is trying to promote increased insulin sensitivity. We also find that sleep deprivation raises the levels of ghrelin, the hunger hormone, and decreases the levels of leptin, which is the hormone that helps us with satiety or helps us with fullness. So to compensate for lower energy levels, many people who don't sleep well may be likely to seek relief in foods that are high in carbohydrate, which may raise blood glucose levels. And that is another factor that affect diabetes management. Also, adults with type 2 diabetes who don't have well-managed blood glucose levels may frequently wake up at night because they're urinating more often. And it may make you more likely to reach for some of those junk foods that are higher in carbs and higher in sugar, which may make it a little bit more difficult or a lot more difficult to manage weight. Individuals with type 2 diabetes do have a higher chance of developing sleep disorders. And two of them that have come to my attention are restless leg syndrome. Approximately 1 in 5 people with type 2 diabetes do have restless leg syndrome. That's marked by a tingling or other irritating sensations in the leg, and that can interfere with falling asleep or staying asleep. That can be caused by nerve damage, and symptoms of peripheral neuropathy are very similar to symptoms of restless leg syndrome. People who experience these symptoms really need to speak to their healthcare provider. And the second one is OSA, or obstructive sleep apnea. That's a sleep disorder in which a person momentarily stops breathing at recurring intervals throughout the night. And in most cases, the person's not aware that this is happening. But if they do have a partner that might notice that they're snoring a lot or gasping for air, that may cause a person to seek a sleep apnea test or a sleep study test to see if they have apnea. There's not a direct connection of where sleep apnea causes type 2 diabetes or type 2 diabetes causes sleep apnea. There is a correlation that many people with type 2 diabetes do have sleep apnea. Also, a lack of sleep can raise blood pressure and seriously increase the risk of a heart attack, and it may make the immune system less likely to fight infections. It increases the risk of depression and anxiety. And I know that many people are also finding that a lack of sleep is also correlated with fear of missing out and being on social media as well. That's something that people talk about all the time. So what can we do during the day? We can get natural light for 30 minutes or more earlier in the day. Exercise, going back to the importance of exercise for at least 20 minutes each and every day. Stop drinking caffeine after 2 p.m. for most people is very helpful and can be very important. In more research on caffeine, some people metabolize caffeine differently than other people. Some people metabolize it quickly. You may work with an individual who says, hey, I can drink coffee or tea or something that contains a high amount of caffeine up until the time I go to bed and it doesn't bother me. And for other people, they do not metabolize caffeine that way, and it affects them very strongly. And try not to eat heavy meals at least 2 to 3 hours before going to bed. And that's also extremely helpful. What can a person do before they go to bed? Minimize screen time, 1 to 2 hours before bed. We have to start to put some boundaries on screen time when important, when we can. So, of course, diabetes devices are on 24/7. People can be wearing CGMs, alarms can be going off. This is obviously something to look at. But what I would ask is using our clinical judgment in concert with the individuals who are seeking our clinical guidance is to find out what they are eating, when they are eating it, when they are exercising, how much caffeine they are using, so that if they're experiencing alarms going off because of high or low blood glucose levels, maybe we can start to minimize that by helping to address other aspects that might be going on earlier in the day. Budget enough time to sleep, at least 7 hours a night. Avoid alcohol at least 1 hour before bed. So the alcohol recommendations are if you do drink alcohol, I'm not recommending to drink alcohol if you don't already drink alcohol, but 1 drink per day for women and no more than 2 drinks per day for men are the general guidelines, being a 5-ounce glass of wine or an ounce and a half of a spirit. Those guidelines are available as well. Optimize your room to be cool, dark, and very quiet. Covering all aspects of light is extremely important as well. Get that sunlight. We know that we have those lamps during the winter that can be helpful as well. So here's something that I find with a lot of my clients. People simply don't always go to bed. Many of us do who may have typical schedules, but a lot of people don't go to bed and wake up at the same time every day. We've seen more of this since people have been working remotely or hybrid since 2020, if that is something. So bedtimes may not be as consistent, and that might be a very helpful recommendation. And look to see if for this individual person, if helping with naps may help. But for most people, taking naps should be limited so that doesn't interfere with naps later on in the day. And my goodness, boost the diet with good nutrition, which can help with sleep. Follow the same bedtime routine. Reduce stress with calming activity when possible. And I know this sounds like a strange line, only use the bed for sleep and sex. I have people who set up picnics in their bed, eating their meals in their bed while they're watching TV. So when it's time to go to sleep, they're not looking at the bed as something that is just used for sleep, and that can interfere with adequate and really good restful sleep. Get out of bed if you can't sleep for more than 20 minutes is recommended, and set your phone to silent if at all possible, not checking the time. The sleep environment, blocking out noise. I like this recommendation of keeping the bedroom temperature cool to 65 to 68 degrees. And every sleep expert that I've spoken to when I was putting this together said, don't overlook the mattress quality and the pillow quality for sleeping. Try aromatherapy and using, as I just said, a high quality pillow and improved ventilation if that is possible. Stop drinking coffee, look for hidden sources of caffeine, and avoid alcohol. Adenosine is a chemical that brings on sleepiness and is released in larger quantities when we are sleep deprived. Coffee promotes alertness and reduces tiredness by blocking adenosine receptors and preventing the chemical from exerting its sleep-promoting effects. So research suggests that the body compensates for this effect by increasing sensitivity to adenosine. Once the effects of the coffee wear off, the resulting surge can cause sleepiness and muscle fatigue. So if you're having that feeling, there might be a specific reason why. For us as healthcare professionals, as clinicians, as well as for the people that we work with who are seeking our clinical guidance, It's so important that during the day, even when you're attending a full day symposium such as this one, to do some mini relaxation exercises focused on breathing techniques, simple breathing techniques to help reduce anxiety and tension, whether your eyes are opened or closed. And you can do these any place at any time to help relax and to help center yourself so that you can continue on with your day's activities. You can, and there were a number of these, but I wanted to show you 2 of these per day. Use them yourselves or use them, please, with the patients that you work with. So the first mini breathing exercise is to count very slowly to yourself from a number down to 0 and each breath. For example, breathe in, and on your first breath out, say 5 to yourself. Next out, 4, working your way down to 0. And when you get to 0, you'll see how you feel. So we're going to inhale, exhale, inhale, inhale, exhale, inhale, and exhale until we get down to 0. And you'll notice that concentrating on your breathing just helps you center yourself for the moment as you're concentrating on that. One more example, as you breathe in, count slowly up to 4. And as you breathe out, count slowly back to 1. And then repeat. So breathe in. And then exhale. 1, 2, 3, 4. And then exhale, 4, 3, 2, 1. I find that it helps me calm down, and it's such an easy and great exercise. Even if you have somebody come to see you who might be anxious about your appointment, it's a great thing to do at the beginning and at the end of the session. And if you're interested, you can reach out to me afterwards. I have a number of those different mini relaxation techniques and exercises. So let me restart my video. So people with type 2 diabetes should be considered in remission after sustaining normal blood glucose levels for 3 months or more. There is no ideal macronutrient pattern for people with diabetes. Everything should always be individualized. A variety of meal plans can be considered for the management of type 2 diabetes. And again, any combination using your clinical judgment and the preferences of the person that you're working with. There is a significant decrease in insulin resistance following post-bariatric surgery. And we looked at a number of different bariatric surgeries, but please know that I didn't include all of them. And a person-centered approach must be used in all aspects of prediabetes and diabetes care. A collaborative, person-first language, person-centered approach. Physical activity increases insulin sensitivity and decreases insulin resistance. And caffeine may block adenosine receptors and prevents its sleep-promoting benefits. I want to thank you very much. And I think I've left a good amount of time for questions, which I appreciate all of them. I really did not watch all of them during the presentation, so I hope to address them now, just because I wanted to get through all of this major amount of material.
Thank you, Susan, for that fantastic presentation. It's so full of valuable information and excellent resources. So yeah, I will go ahead and just ask you those questions that came in. So the first question was, if normal A1C is considered below 5.7%, why is this not the standard of remission? Isn't an A1C of 5.7 to 6.4 still considered as pre-diabetes?
Yeah, that's a great question. So that's based on the remission statement. I believe that consensus report was based on a person, if I'm remembering the studies correctly, coming down from a higher A1C of over 7 for that report. But you are correct. Those lower numbers are what we are considering for pre-diabetes and for the beginning of type 2 diabetes. But in the consensus report, that was what they used as their parameters. And that was based on, I think, the data that they all used to put in for a person that was coming from a higher A1C. So yes, that was a correct statement.
Okay, great. Okay, does it matter if fiber is soluble versus insoluble?
Yes, they both have completely different benefits. So that's why we want a variety of different types of soluble and insoluble fiber. So and they should both be included in the diet. So certain types of fibers are needed to help reduce cholesterol levels, others to help manage blood glucose levels, others to help with satiety and for a number of different benefits. So eating fiber from all different sources is really very important. And again, fiber coming from lower carbohydrate, high vitamin and nutrient-packed vegetables is really important. However, we also want to get fiber from beans and legumes, for example. And some patients may want fiber coming from whole grains and from sources such as that. So both fiber coming from soluble and insoluble sources are, yes, both highly recommended.
Perfect. Thank you. Okay, the next question is, my concern with using the plate method is that it seems to endorse choosing only 15 to 20 grams of carbohydrate per meal. If the recommendations from the ADA endorse teaching materials I use in education endorse 30 to 45 per meal for women and 45 to 60 for men, why would we endorse such a low carb goal? I'm concerned that it sets an unsustainable goal for patients. Those that are not RDs take this as the gold standard and seem not to understand the long-term sustainability and nutrition benefits of a modest carb diet.
That's such a fantastic and well thought out question. So thank you for that. What many people people living with diabetes in the community have been asking, which is why I believe the plate method and the low carbohydrate plate method were developed. And there's a great publication that ADA produced last year for healthcare professionals on advising people who want to absorb the option of a lower carbohydrate intake. So maybe we can share that resource at the end of the symposium as well. I think it might be in my resource list. So it shows healthcare professionals how to address that. The reason that was developed is that people are asking for that as an option. So where the educational materials will sometimes suggest that, for example, the low-fat eating pattern may have a higher carbohydrate intake, or some of the general recommendations may have a higher carbohydrate intake. People are requesting some of the lower carbohydrate options because of some of the information showing that for certain people with type 2 diabetes and with prediabetes, it may show the best response for reduced glycemia and for decreased glycemic variability. Your point is extremely well taken, that unless it is planned with a healthcare professional who is able to make sure that there is enough nutrition, calories, vitamins, minerals, etc., in the rest of the eating pattern, then that could be an absolute issue. The food plate method is a down and dirty nutrition education that is used for some as a quick resource. It is not the be-all, end-all. For some people, consuming upwards of a higher amount of carbohydrate that might be recommended, a lot of people, don't subscribe to that way of eating. So it has to be very individualized, and we have to look at all options. And to me, again, just to reiterate that, in my practice, it was people also asking for other options of how they can reduce their carbohydrate intake. And we work on it to make sure that all of the different aspects of nutrition, well-being are also incorporated into that. And if you have more questions or want to discuss that with me further, please reach out to me. My contact information is on here, and I would be happy to further one clinician to another how we approach that question.
Great, thank you. Okay, another question is, given the stress response can cause a spike in blood glucose, what would help ease the participants' anxiety or confusion when we state the benefits of exercise and blood glucose?
That's such a good question. So once they are strength training more often or resistance training more often, which again, those are small bouts that cannot be sustained for a long time, they will see it will be more consistent in what their response will be over time. And what I do is I let them know that that might happen. We may modify their nutrition plan accordingly because of it. But as I also stated in the presentation, I may move around how they're exercising. I may put that at the top of the exercise routine and put aerobic activity, even if it's an amount of walking or cycling for, going on a bike for a little bit after that, or just some movement after it, which is going to lower blood glucose. So we work around it, and we discuss it so they know what their expectations are. And don't forget to use those breathing exercises to have people calm down when you explain these things to them.
Great, thank you. Okay, another is, often we hear that a protein choice should be included at meals and snacks for persons with diabetes or gestational diabetes or when treating hypoglycemia. My understanding is this recommendation is not supported by research and was addressed in Diabetes Standards of Care several years ago. Can you please clarify?
So that is something, back decades ago in my training, that was something we were taught. It has not been supported by evidence in recent years, but I will say this. When I'm working with the people in who I work with clinically and in my practice, I do still individually recommend that based on what their response is on their CGM or when they're checking their blood glucose levels. And the reason is sometimes portion management and management of what they're eating just as a whole in a snack more often than a meal when we're talking about the protein. And also it may not affect directly the blood glucose level, you're right, but it may affect the nutrient content of the meal, and it may also, in terms of portion, increase the carbohydrate content of the meal. Sometimes of protein and adequate fiber is not in there because they'll eat more of the carbohydrate food and less of the protein food if it's not something that they're pairing it with. So I look at it as a way to get enough nutrition in, but I will also look at it to see if it helps with blood glucose management. I think that's kind of individualized.
Yeah, I agree. Okay. And then another question is, do fatty food choices cause insulin resistance immediately after consuming choices such as pizza or fried food?
Right. So fat, we sometimes forget to look at fat and the delayed response, especially if a person is taking insulin. That we may see a rise in blood glucose levels. We may have to do a bolus that is cut in certain ways, or is a dual squared bolus in certain ways, because we have to think about for the very high fat meal when blood glucose may peak. So yes, we look at everything. We want to look at carbohydrate, protein, and fat in meals to see what the blood glucose level will be responsive to. And it's a very important point, because although carbohydrates are the foods that raise blood glucose levels the fastest and often the most, obviously, protein and fat can affect it as well. Protein will affect blood glucose levels depending on the amount of carbohydrate you also have in the diet. And also fat has that delayed response. So we have to monitor, and this is why blood glucose checking, testing, and CGMs can be so helpful in terms of that data.
Okay, and Another question is, what about net carbs? Should we just have patients read total carbs on labels and ignore net carbs?
Net carbs is a term that was, can I use the word, made up by the food industry, which is why you see it less and less often. You will see it on very low carbohydrate, like kind of keto websites of what the net carbs is. So that is not something that I use in my practice. I do look at fiber content. I do look at total carbohydrates, and I look at added sugars in terms of that those sugars do not bring additional nutritional benefits to the person that I'm working with. So we know that added sugars come in many different forms. Many people consume sugar sweetened beverages, which is a big source of added sugars. So I look at that. Net carbs you do not see consistently across food labels because it is not an approved term. It is used by certain manufacturers, but it's not an approved term.
Got it. Thank you. Now I'll just ask one last question, although there are a few more. It says, I have many patients who ask me if they go into diabetes remission, can the diagnosis go away from their medical chart? Or will they still be labeled type 2, that they have type 2 diabetes as controlled?
Right. So you see why language is so important. And I was very careful, and I said it a number of times, and sort of the consensus statement, it's remission, not diabetes reversal. And people don't like to be labeled as anything. Diabetes is only a part of people. It shouldn't define them as a person. So I don't know, across all spectrums, if that is removed or if it's stated that a person's in remission. My guess is that it's going to stay. I don't know if I would definitely share that, but it probably will stay there because it was part of the medical record. So we use the word remission and we follow remission, careful not to use the word reversal. We do not know the long term, even if a person did have the effects of, let's say, bariatric surgery, which again, not a recommendation, just looking at the effects on remission. Even if a person does lose weight, if that is part of helping them get in remission, even if they do modify their eating pattern to get in remission, we do not know if that is long-term sustainable or if it works across the board for everybody. So the way that we discuss it with people and the way that we support people is just so important. And celebrating those wins and being positive, using person-first language and collaborating with the person who has the lived experience, making changes in our clinical management plan as they make changes throughout their lives.
Thank you, Susan. Couldn't agree with you more. So if there are other questions, as Susan said, you can send her an email.
Please.
All these slides will be available as handout. We will email them after the symposium. So with that, we will go to the next slide. We'll get all these references. And now we will go to a 15-minute break.
Thank you, everybody.
Thank you so much, Susan. Thank you, Uzma. So we will join back 15 minutes